Hey everyone, welcome to this explainer on the medical legal realities of dermatology. Today we're taking comprehensive, evidence-based data and translating it into actionable patient safety systems. Let's jump right in.
Now, just to set the stage, this presentation was prepared by Dr. Thomas Hocker. He's a Harvard and Mayo Clinic-trained triple board-certified dermatologist, Mohs surgeon, and dermatopathologist. So what we're looking at reflects his specific opinions and deep expertise, and it was medically reviewed for up-to-date accuracy on July 6th, 2026. Oh, and a quick reminder before we dive into the data, this is a professional risk management discussion. It's not legal advice, and it's definitely not personal medical advice. Laws vary wildly state by state, so you'll want to consult qualified counsel for any jurisdiction-specific questions.
Okay, here's the core hook for our entire discussion today. I want you to read this quote with me. The lawsuit dermatologists fear is often not cinematic. It is the loop that quietly failed. And man, that is so true. The reality of dermatology malpractice, it's rarely some dramatic surgical disaster. Instead, it's that atypical mole you decided to just watch. It's the pathology results sitting unread in a digital inbox, or a totally misunderstood cosmetic consent form. To tackle this, we're using a really practical decision framework today. We'll cover the 3 biggest risks: missed cancer and diagnostic gaps, cosmetic risks and consent, systems, pathology, and medication, malpractice myths versus facts, and finally, a Monday morning safety checklist.
All right, Section 1, the 3 biggest risks. Let's look at what actually drives these claims.
So even though dermatology boasts a pretty low average indemnity payment overall, the reality is about 75% of practitioners are still going to face a legal claim by age 65. But here's the interesting part. When those claims actually succeed, they almost always cluster around just 3 predictable failures. We're talking missed skin cancers like melanoma, procedural complications, mostly from lasers and injectables, and communication failures regarding informed consent and result notification. Now, our goal here is absolutely not to practice scared medicine. The goal is to build ironclad systems that catch these predictable failures long before they ever reach a courtroom. Let's move on to Section 2, missed cancer and diagnostic gaps. These are the claims that truly cost the most. We really need to dive into the most financially devastating category across the board: missed or delayed skin cancer diagnoses, specifically melanoma and keratinocyte carcinoma. Take a look at this number: $436,843. Melanoma is literally the single most dominant diagnosis by financial impact in our field. These claims are paid out about 42% of the time, and that average indemnity is nearly $500,000. The consequences of missed melanoma are, of course, absolutely devastating for the patient. But a delayed diagnosis, that's the quiet killer of dermatology practices. And right here, we have a crucial diagnostic gap we've got to talk about. Visual diagnostic accuracy actually drops significantly for skin of color, going from about 72.1% in late skin all the way down to 52.8%. Because of this, melanoma often presents at much more advanced stages in patients with skin of color, especially amelanotic or acromelanomas on the palms and soles. So what does this mean for you? You've got to maintain a meticulously low biopsy threshold for atypical lesions in these patients, and make sure you're adopting your photography standards with proper lighting. It's absolutely crucial. Up next, Section 3, cosmetic risks and consent. This is all about those elective complications. So cosmetic and procedural risks actually generate the highest overall volume of total claims. Why? Mostly due to unmet expectations and elective complications. But here is a massive liability risk you might not be thinking about: non-physician operators. They are involved in a staggering 71% of laser lawsuits regarding burns, scars, and dyschromia. Delegating these procedures without adequate on-site supervision triggers vicarious liability or respondeat superior for the supervising physician. Look, if you own a medical spa, hear me now, this is your highest growth liability area by far. Which brings us to a really key point. Informed consent is a documented conversation. It is not just a signature on a form. I repeat, a signed piece of paper is not enough. Your chart has to reflect that a meaningful conversation actually took place. You need to discuss specific material risks, like vascular occlusion with fillers, talk about reasonable alternatives, and have a clear, documented acknowledgement from the patient that cosmetic outcomes are simply never guaranteed. All right, Section 4, systems, pathology, and medication. Let's talk about internal tracking. Moving from the procedure room to clinic operations, your practice's internal tracking systems are very often your strongest legal defense. So, here's a step-by-step decision tree for your pathology workflow. Step 1, always provide clear clinical context to the dermatopathologist. Step 2, make sure you reconcile any clinical pathological discordance. Step 3, track literally every single biopsy through a closed-loop system. And Step 4, directly communicate all results. You absolutely must adopt a strict no news is not good news communication policy. Think about it. A single missed result notification can easily become a $400,000 claim.
We also need to touch on medication risk, specifically isotretinoin. Now, large meta-analyses have pretty much disproven the old myth that it causes inflammatory bowel disease. But the failure to actually monitor these patients and the failure to document mandatory psychiatric screening, that remains a statistically significant liability. Your system has to remember the things that a busy clinician might easily forget on a chaotic Tuesday afternoon. Moving into Section 5, Malpractice Myths versus Facts. Let's dispel some of these practice rumors.
Let's cut right through the noise and bust some of those pervasive anxiety-driven rumors floating around the dermatology community. Myth number 1. Just biopsy everything to stay safe. The fact? Reflexive over-biopsying is defensive medicine. It is not good medicine. It just increases costs without actually eliminating your risk. What actually protects you is clearly documenting your clinical reasoning when you choose not to biopsy, and carefully obtaining an informed refusal when a patient declines a recommendation.
Okay, myth number 2. Shave biopsies are totally fine for suspected melanoma. Fact. Superficial shave biopsies are a massive trap for suspected melanoma. Get this. Partial biopsies carry a 4.5 times higher misdiagnosis risk compared to complete excisions. In fact, more than 80% of melanoma malpractice claims involved incomplete biopsy specimens. The takeaway? If you even suspect melanoma, you have to use the proper diagnostic specimen.
And myth number 3, my EHR automatically tracks everything, so I'm covered. The fact here is you should never assume technology alone protects you. Excessive template-generated documentation and those convenient copy-forward features, they actually introduce errors and can completely obscure your actual relevant medical reasoning. For true patient safety, a manual or active electronic reconciliation is 100% required. Finally, Section 6, Monday Morning Safety Checklist. Let's look at some actionable frameworks.
To synthesize everything we've talked about into a tool you can actually use, grab your phone and take a screenshot of this checklist right now. 1. Document your clinical reasoning and informed refusals. 2. Maintain a closed-loop biopsy tracking log. 3. Notify your patients of all results, yes, both benign and malignant. 4. Document specific risks in your consent conversations. And 5. Directly supervise your non-physician operators. Use this Monday morning checklist to shift away from scared medicine and move toward highly reliable systems.
Ultimately, the most protective habits you can build are honestly pretty boring and repeatable. It's about building systems that make excellent care harder to mess up. So if you remember just one clear line from this explainer, let it be the safe next step. Biopsy thoughtfully, consent specifically, track relentlessly, document reasoning, and close every single loop. Thanks so much for learning with me today, and I'll catch you on the next explainer.